I'm Dan Collins with Mercy Medical Center in Baltimore, Maryland, and you're watching Medoscopy. Thank you for joining us for today's procedure. Our guests are neurologists Dr. Bonnie Gerecke and Dr. Jason Rosenberg of the Neurology Center at Mercy. Okay, first a little background. Why neurology? Why medicine? Is this something that was always of interest to you both?
So my story was a little bit roundabout. I was interested in biology always. As young as I can remember, I was turning over rocks in streams and getting bugs and insects and all sorts of things. In college, I got interested in animal behavior and evolution. I was actually fortunate enough to take a course with Stephen Jay Gould even, and really got me passionate about the environment. And then I thought, well, I ought to learn about animal behavior. And I took an animal behavior course, and I said, well, I ought to know how nerves work. And that led me into neuroscience and human psychology and human behavior. And then I ended up getting very confused at that point, deciding between biology and medicine, worked at a lab, did some research after college, and decided that medicine was definitely the place where I fit best, and followed that neurological pathway right into neurology. So it was a little bit roundabout. It started because I like to play outside and turned into medicine.
Dr. Gerecke?
My course may be a little bit more direct. I think I've always wanted to be a doctor when I was, you look at this kindergarten, what I want to be when I grow up. It was a doctor. I'm not sure why. I didn't have anyone in my family. It just was something I was always interested in, and always was sort of the caregiver, nurturing one amongst my friends, and had a tend to like sciences. And then in medical school, I actually thought I was going to be an orthopedic doctor because I have a very strong passion for sports. But when I did my neurology rotation, I was hooked immediately. Neurology is a discipline that's very much about patient interaction, taking a patient's history and listening to patient stories, which really drew me in. And a lot of it's what we call localizing the lesion and using the patient's information and putting the information together to come up with a diagnosis and plan. And that really just sort of drew me in and never looked back from there.
Now, neurology kind of covers a lot of different things. I think a lot of people may not even know what different conditions and so forth falls under a neurologist's purview. Now, you specialize, Dr. Gerecke, in neuromuscular diseases. Now, what falls under that particular umbrella?
So an easy way to break down neurology, maybe simplistic, is sort of there's the central nervous system and the peripheral nervous system. So the central nervous system is the brain and spinal cord, and then the nerves and everything else sort of after the spinal cord is the peripheral nervous system. So neuromuscular doctors study the nerves and muscles. We don't care as much about the brain and the spinal cord as much. And so it involves any disease that affects nerves. So people who have neuropathies, carpal tunnel syndrome, symptoms of numbness and tingling or weakness, myasthenia gravis, conditions like that affect nerves and muscles and not so much brain pathology. That's sort of a simple way to break it down.
Well, you mentioned myasthenia gravis. There's also muscular dystrophy. There's been some research, the National Institutes of Health showed that these types of neurological disorders are continuing to increase. What do you both think that is?
I have a couple things to say about that. So first I will say that as a whole, neurological diseases are increasing. There's an increased prevalence because of the aging of the population, right? So not just incidence, but if people are living longer, they're more likely to have disease. So diseases like Alzheimer's, even migraines, multiple sclerosis. If you look at, increasing incidence, we're probably doing a better job of diagnosing conditions. There's certainly environmental factors that are contributing to probably increased incidence of certain diseases. Lifestyle habits. So for example, diabetic neuropathy, there's been a threefold increase since the 1990s to now in terms of the incidence of diabetic neuropathy, one condition. And again, that lot has to do with lifestyle, diet, nutrition, and malnutrition. So a lot of those factors play into the increase in these diseases. In fact, I think that recently there's been an article published that neurological disorders has taken over as the highest amount of disability, took over cardiovascular diseases. For about almost half the population has a neurological disease worldwide, which is a stark number.
Yeah. Patients are also beginning to survive longer with some of these diseases, so things that would be cut life short, they're now living with, and so that increases the burden for the entire population having an illness. Parkinson's has been an interesting story. There's an environmental component to that we've always known about, something about pesticides, other things. Turns out that there was a solvent used in paint thinner and a lot of dry cleaning and industrial chemicals processes that was very widespread in the 70s and 80s. And so the fear is that there's going to be a big wave of Parkinson's coming in the future as well from that. I'm a headache subspecialist, and so in that area, we're seeing an increased prevalence dating all the way as early as adolescence, and obesity has turned out to be a very high correlating factor with that. We're not sure what the causal component of that is, if that's a marker or if it's something about the fat cells themselves producing inflammatory compounds and chemicals. Screen time is another thing that has been correlated as well. So yeah, neurology is sort of getting to the point where it's being recognized better. We've got treatment so patients are living longer, but then we are doing things in the environment and our lifestyles that's also increasing the incidence of some of these diseases.
Dr. Rosenberg, you hold a board certification from the American Board of Psychiatry and Neurology. What's the connection between those two disciplines?
So if you're a neurologist, that's the governing board for us. If you're a psychiatrist, that's the governing board. There's been this arbitrary line in the sand, but in general, if you think that the mind is what the brain does, that distinction is definitely fuzzy on the edges. Often the distinction was that in neurology, you could see it on a test, and psychiatry, you could see it on a quiz. But there are a lot of diseases that sort of don't follow that rubric, especially now that there's functional imaging scans that can show somebody with a psychiatric disease. You can distinguish them from a normal population. And there are some neurologic diseases that are also diagnosed entirely by history. Migraine, we know it when we see it. It's defined, as are most headache disorders, by a set of criteria, and there is no test for it. There's no what we call a biomarker. So there are increasingly biomarkers for psychiatric diseases, and there are some neurologic diseases that don't have biomarkers. When we're board certified as neurologists, we have to specifically pass a percentage of questions that are psychiatric in nature, and psychiatrists have to pass a certain percentage of the neurology questions. And so it's one governing board for both areas. And with a lot of our conditions, as you can imagine, there's comorbid psychiatric illnesses. People with chronic diseases, they tend to cluster together. Sometimes psychiatric symptoms can be the primary symptom of a neurologic disorder as well. So it's important for us to be able to, at least dabble in both fields.
But I will say it can be a little confusing for patients. I think sometimes, I know when they're in an exam room and they're laying in a bed and I'm doing a test and they see, psychiatry and neurology, they might ask a question that's beyond the scope of my expertise. And I'd say, I'm not a psychiatrist. And I say, well, what about that? So it is a little confusing for patients, I think. But I think that's somewhat academic, probably.
Now, Dr. Rosenberg, in an interview you did once, you mentioned there is a lag between the diagnosis and treatment of someone dealing with chronic headache or migraine as being about 5 years. Why so long?
There are many reasons. Partly there wasn't a widespread education campaign, and now there are education campaigns out there. Part of it was physicians. The most common misdiagnoses for migraine is sinus headaches, which is really a sort of Madison Avenue myth. They really don't exist. And for years, patients and providers, largely due to decongestant commercials and sinus medicine commercials, have been convinced that sinuses hurt. They usually don't. They cause congestion and infection and other things like that, loss of smell, foul taste, cough. But they almost never are associated with pain, and there were several consensus statements that came out by groups of sort of allergists, neurologists, primary care providers, ENTs, and they actually formally came out with this statement that sinus headaches as a whole don't exist, and about 90% of people who meet criteria for, about 90% of patients who have what they believe to be, or were told by a primary care provider had sinus headaches, in fact have migraine. So some of it is lack of education, some of it is countervailing myths and wisdom that is just incorrect. And then patients don't know where to go. And a lot of us in medical school, we may have part of one lecture on headache. And so medical school curriculums have also not been very good at keeping up with a very prevalent condition.
Interesting about the sinus headache, which is really migraine.
Yeah.
Sounds like a topic for our woman's doctor program. Now, you're both native Marylanders, being from Potomac and Baltimore, or Potomac and Baltimore?
Yes. Baltimore all the way.
I've actually read a statistic that 75% of all Baltimoreans are native Marylanders. So why stay here? Why did you decide to stay within the borders of Maryland?
Well, I'm not from Baltimore, so I think I'm from Silver Spring, Potomac, which is actually quite different than Baltimore. I will say it's like it's still Maryland, but my football team is different than the football team here. I am an Orioles fan because that's all we had when I was young. But I think there's a lot this area has to offer. I think there's a lot of culture, whether you like sports, whether you like arts, you're near the beach, you're near the city. I think there's access to the outdoors. I really actually think the climate's moderate. I think there's a lot that you can offer. And personally for me, being near family was the most important choice. Also, obviously, having access to great health care, both as a patient or for family members who need it, and to be able to practice in a place where you have very rich, medicine and colleagues and access is really an added bonus, too.
Baltimore was it for you?
I grew up here, moved around a little bit, but grew up here, went to college in Boston, came back to Baltimore to work. Just convenient. Got to know the city as a resident rather than as a child at that point. And I said, hey, this actually is affordable. There's a lot to offer, a lot of outdoor, a lot of activity, a lot of cultures, a lot of medicine, a lot of science. Went back to Boston for medical school, interviewed all over the country from between Atlanta and Seattle. So really, literally the entire country. And ended up in the residency matching program, matching at Hopkins, came back here and really established a life, met my wife, and ended up staying. And it's been good to me. And I try to give back to the city, which obviously has its problems. And at this point, I'm just outside. I'm in the suburbs, but I still feel loyal to the town.
We'll take a break and return after this message.
Fatigue is a common symptom for many things, especially when you're talking about difficult to diagnose autoimmune disorders like myasthenia gravis. The disorder is more common in women under 40. As they work to discover why, they say living with myasthenia gravis is better than before.
Arms up like that for me. We're going to push them down a couple times and see if you develop any weakness.
Shirley Terrell has spent a lot of time with doctors over the last 17 years. She was diagnosed in 1997 with myasthenia gravis.
When I first started having the symptoms, it's like having something wrong and you don't know. And
not knowing was scary. Even though it was a long time ago, the Baltimore grandmother says getting the news she had myasthenia gravis was alarming. Many doctors, like neurologist Bonnie Gerecke with Mercy Medical Center, say it's common for people to react that way.
It's a neuromuscular disorder in which patients develop weakness in the skeletal muscles, the voluntary muscles of their body. The term myasthenia gravis comes from Greek and Latin, from gravis means severe and myasthenia is muscle weakness. And this is sort of a misnomer these days because that term was coined when there were not good treatments for the condition.
Dr. Gerecke says now there are.
Now, with good treatment, most patients are asymptomatic, have normal lifestyle and a normal life expectancy. Look over here. Good. No double vision?
it looks a little.
Shirley wanted to see Dr. Gerecke because her eye is bothering her. It's a common symptom. It can easily be helped through medication. Shirley says most days she doesn't even think about having myasthenia gravis.
I don't want to think about the negative because there's so much positiveness in it. You know, I'm doing great with it now.
And Dr. Gerecke is glad patients like Shirley will open up about it so more people can know it's manageable.